Hi, so I'm going to be talking about a human factors approach to reducing risk and really talk about some of the work that we've been doing looking at preventing never events and how you can look at the system and how try to design engineered solutions to prevent them from happening. So just very quickly, so a lot of our innovations, I'm an entrepreneur, our innovations have been funded by the Academic Health Science Networks. I'm a fellow on the Innovation Accelerator Programme, on the Clinical Entrepreneur Programme, and both of these were set up by NHS England and supported and funded not only to develop innovations, but to spread them, because innovation is good, and getting good innovations into practice is a good thing. So if there are any people that have any ideas or any entrepreneurs, apply to these programs because they are absolutely fantastic. So I'm going to be taking you through a particular type of innovation that I'm doing and that we've done and kind of how we did it. So I'm going to be talking about central lines, and when you do a central line, you routinely do a chest x-ray after the procedure to check the position of the catheter and to check for any complications such as pneumothoraces and things like that. But if you read the blurb of my talk, you will have seen the Guidewire, obviously, on the chest x-ray, which is right there, and that's actually what my talk is about, is retained guide wires. So this is when a guide wire gets accidentally forgotten by the clinician, it's left inside the patient, and it's a retained foreign object and is a never event. So when these happen, they can embolize to the heart. You can have complications such as AF, thrombosis, cardiac perforation. It's got a reported mortality of about 20%, and it requires urgent removal, so either interventional radiology or a cardiac surgeon. And the incidence in the literature is reported to is 1 in 3,200 procedures. The actual reported incidence to NHS England is about 2 a month. And if you think about the number of central lines that are put in, there is quite a discrepancy between those numbers. And it's not an insubstantial problem. This is from the Royal College of Emergency Medicine, and they said over 2 years, half of all their never events were retained guide wires. So this is a common problem. And it's really interesting when you read the literature. So in the literature, this is why people think it happens. So they talk about inexperience, they talk about inattention, distraction, junior doctors aren't supervised properly, they have too much high workload, they've got staff fatigue, and people make mistakes. And these same people say this is how you can address these problems. So we've got to re-educate and we've got to retrain people. We've got to have reminders to remember to remove the guide wire. You can introduce checklists, you can do a 2-person approach, you can have active supervision of junior doctors. And whilst this is not recommended, it's still done. Blame the individual, which is still really sad, but happens. And when you actually look, so this is the data from the NRLS of retained guide wires over 10 years, which I was very gratefully given to by NHS England. And you can see the incidence of these retained guide wires over these years. And you could say, well, that's just better reporting. People are reporting it better, and that's why the incidence has gone up. But actually, if any of these mechanisms were working, this should be plateauing or it should be going down. Okay, so what's actually happening? Well, so I'm going to argue that with this type of error, these kind of mechanisms of prevention, they're laudable, but they're not sustainable because they don't address the problem. And that's because the technique is based on the clinician remembering not to make the mistake. And if you just rely on the operator to prevent the mistake, it's not going to be effective. And another point, which is probably a bit of a bugbear for me, was that people kind of go, well, a checklist is free, or just making sure people watch them properly is free. And it's not, because it's time consuming, and the time that that a clinician is taking to do that is actually taking them away from other clinical things as well, and that actually costs money. So if you ever think about how much time and effort it takes to put a checklist in, it costs money. So this is a really interesting bit of work by Cavazo and Sincere, and it's looking at risk management theory, and it's looking at the intervention of effectiveness, and it looks at how people-focused and system-focused interventions. And if you focus on people-focused interventions, they're not as effective as if you can focus on system-focused. So the best ones that you can do is trying to get things like automation and forcing functions. And if you can do that for a procedure, then that's really what you should be aiming for. So I want to tell you how we did this with the example of central lines and retained guide wires. So this is all of the equipment that you need to complete the procedure to do a central line. So this is what your trolley looks like when you're doing your procedure. And this is all the steps that you need to complete to actually place a central line, right from preparing the trolley to doing the paperwork to doing a chest X-ray at the end of it. So when we looked at the NRLS data over 10 years, the point of recognition of Guidewire retention was really quite interesting. More than half of them were recognised after the first check chest X-ray. So this is on a subsequent radiological image, or subsequent intervention with the catheter. That's when they were discovered. Only 23% were discovered on the chest X-ray, and actually only 22% were discovered when the paperwork was signed. And if you think about when these checklists and reminders are done, when do you do the paperwork to do the checklists and the reminders? It's after the procedure, so it's after everything's completed. So that's not going to remind you. But there's a thing about never events and rare errors is that you do this procedure so many times, you don't think you've made this error. So there are loads of cases in the literature and reported to NHS England where people have ticked the paperwork and signed it saying, I've removed the guide wire, of course I have. And then you see it a couple of days later on the chest X-ray that it's there. So we started looking at this whole procedure, and I've done them, but actually what you need to do is go and observe what people are doing, literally watch what they're doing and how they're doing it, because there's so much variation. And these are all the points in which Guidewire is used in the procedure. Okay, so that's the only point. And this is the only place when the Guidewire can be forgotten, because you don't need it afterwards. So if you've forgotten it at that point, there is no mechanism or reminder or thing, other than when you're signing your paperwork at the end, to tell you that you haven't got the guide wire. So you just complete the procedure and carry on. So what you need is a solution at this point. And so that's what we did. So we're going back to our trolley, and here we go. This is our central line again. And what we did was we took all of this equipment, and this is everything that you need to complete the procedure after you've not removed the guide wire. So you've got your dressing, your suture, and your flushes and things, and like that. And that's all there, and that's everything you need to complete the procedure after you remove the guide wire. And what we did was we took all of those things, and I've left my wire safe over there, and I put it inside a box, which my glamorous assistant will demonstrate. There we go. Thank you. Yeah, we put it inside this box, and that's it. And we called it the wire safe. So this is what your trolley looks like, and this is what your setup is. And the only way that you can access the contents to be able to get into the box is to use the guide wire as a key to open it. So that's what you do. So that's it. There you go. So now you can complete your procedure. And it's a really simple mechanism. It forces the clinician to always remove the guide wire, because they physically cannot complete the procedure without it. And it makes sure that they always remember to do it. And the thing about guide wires and central lines, if you think about what's happening when you're doing this procedure, the central line isn't the only thing that's going on with the patient. There are so many other things that are going on with the patient. And to focus all your energy and attention on a guide wire is not what's in the best interest for the patient. What you need is something that lets you do it, prevents you from making the error, and move on. So in terms of never events, this is how we've kind of looked at it. And at the end of it, you want to make it really convenient for the user as well. So we put you can put all your sharps inside there, you can close it, and then you can take it over to your bin. You can drop the contents in there, and or you can just shove this box straight in there. And it makes it really convenient, and reduces needle stick injuries as well. So we talked about testing and doing studies and things. We have done so many studies on this, and so our simulation studies have shown that it's 100% effective in preventing guide wire retention. We've had well over 3,000 uses in our own institution, and it's bound to be significantly quicker using the wire safe than kind of standard practice. And you may wonder why that is. But if you actually watch, and this is the thing about watching these procedures when you're looking at preventing errors, so your patient is here but your trolley is here. So you're going backwards and forwards all the time between the patient and the trolley, turning around to get all your equipment. Whereas with this, what's really great about it, and actually it wasn't something that we discovered, it was one of our juniors discovered this, you can just pick this up and put it right next to the patient. And it makes it so easy because you have all of your equipment right there to be able to secure the catheter. And that's why it's quicker. And that's why it's quicker. And we found, really good feedback. So, it's easier to use, or no difference completely. And people really like it, and they want to use it for the safety benefits. So one of the things about designing, particularly for preventing never events, is that you've got to make it work for the clinician as well, because they've got to like being able to use it, as well as making it safe for the patient as a priority. But you don't just stop there. You can make things better. So people always talk about, marginal gains and why, all these kind of things. So what we did was actually improve the contents. So there's a study from the CDC which said that you're 8 times more likely to get a needle stick injury if you use a straight suture, so a straight needle and hand suturing, which then if you use a curved suture, a needle holder, and a countertraction forceps. I mean, that's obvious, isn't it? But we still give our junior doctors straight needles and say, get on with it. So this is what we did. We said, we're going to give you a dressing, a curved suture, suture holder, countertraction forceps, and a pair of scissors to actually cut them rather than using the blade, so you're less likely to have needle stick injuries. You've got to make it good for staff as well, and that's really important. So I'm just going to leave you with this again, and it's not to say that checklists aren't great. There are particular times when checklists are really good and they're really important. But if you can find that little mechanism or that forcing function where you can do it, then these are the best places to. That's the best way to prevent it. And I've done mine very quickly, but thanks very much.